Hi everyone, welcome to Pharmacology for Nursing Practice. So this is going to be your first lecture. So let me first show you how to find your lecture. So you can access it from your homepage by clicking Unit 1, or you can also directly go to Modules. So if you click Modules, and this will look a little bit different from yours because this is the instructor version. And when you scroll down, you can see Unit 1, Fundamentals of Pharmacology. So you have two options here. You can use this one right here, which is basically your outline. You can print it, or if you want to just save it as a file, or you can just open it from Canvas. Or we can also go back to, if you want to go back to that same page, or if you press next, you can open the PowerPoint from there. So this will be a PowerPoint version of your handout. So whatever works for you, that's fine. It's going to be very similar. It will have basically the same or very similar information. So depending on your learning style, you can use either or. But if you want to save on ink, definitely the outline will probably work best for you. And as for me, I'm going to be using PowerPoints to present to you. All right, so are you guys ready? This is Unit 1, Fundamentals of Pharmacology. So basically what we're going to talk about here is just a basic foundation, basic information, understanding and knowing drug categories, and some applicable terminology, and also what are the responsibilities of nurses and what do we do during the nursing process. And also we're going to talk about legal and ethical issues associated with medication administration. So these are going to be your objectives. Make sure you read them carefully. So this is our goal for this Unit 1 lecture. This is a continuation of your objectives, and these are going to be your reading assignments. So at the bottom of that page, assignment says read. So you have chapter 1, chapter 4, 5, 6, and 7. And this is just for supplemental or as your resource. You don't have to read everything page by page, everything really that you need to know, at least for the objectives of this course. And for exams, it should be within your lectures and your handouts or outlines. But definitely, if there's something that you don't understand and you want to read more about it, feel free to read your book, and that's why you have it. So again, Unit 1, Fundamentals of Pharmacology. We're going to start by talking about the nursing process. So you're going to be hearing this a lot. So what is the nursing process? So nursing process is a research-supported organizational framework for professional nursing practice. So basically, this guides us nurses on like what are the things that we do for our patients. So it ensures the delivery of thorough, individualized, and quality nursing care to patients. So this basically enables consistency. And definitely this requires critical thinking. Now, you're going to hear this a lot, critical thinking. It's not necessarily the exact same thing as logic. There are interrelated, but in nursing, when you hear critical thinking, is basically the ability to prioritize certain things depending on your patient's specific scenario or case. Now, the nursing process is ongoing and constantly evolving. So it doesn't mean that you have this plan for one patient, let's say patient A, it doesn't always apply to patient B. And not only that, even with patient B, like on day 1, they may need something else. So your priority will be different from day 2. So keep that in mind. So it's ongoing, it's constantly changing. So there are 5 steps in the nursing process. So you have number 1, assessment, number 2, nursing diagnosis, 3, planning, which consists of goals, outcome criteria, and 4, implementation, including patient education, and 5, evaluation. So during your assessment, that's when you collect your data. That's when you're trying to find information about your patient's condition, about what's going on with your patient. So assessment is the collection, review, and analysis of data. So there's going to be different kind of information that you can gather. You have your subjective and objective information. So subjective would be whatever the patient says it is. One of the most common things or common subjective information would be your patient's pain level. So pain level or even the quality of pain, that's subjective. That's whatever it is that your patient says it is. Now, what is objective? So objective, on the other hand, is something that you can observe. So there's tangible or concrete things that you can see, touch, feel, read. So a big part of your objective data would be your past medical history or PMH. And you also have your medication history, which will include your patient's social history. So alcohol use, tobacco, caffeine, and other things, right? So within that medication history, you want to know your patient's medication profile. So not only a list of medication, right? So you want to know everything that they're on, whether it's prescribed or not, whether it's over the counter, if it's just vitamins, herbs, supplements. And not only that, yes, they have prescribed medications, but are they compliant, right? Are they taking it the way the doctor said they should take it? And one big thing also is, do they have any allergies, right? And make sure that whenever a patient reports that they have an allergy, you want to ask what kind of reaction do they get? Because sometimes they may think it's an allergic reaction where in fact it's probably a side effect or another adverse reaction or sensitivity. It doesn't always mean allergies. So make sure that whenever allergies are reported, you ask what reaction are they getting? Okay, now we go back to nursing diagnosis or problem list. So in this step of the nursing process, we basically identify what's going on, what's the problem, or what's wrong. So this is your equivalent to, let's say, your medical diagnosis, but because we're nurses, we can't do a medical diagnosis per se. So initially, or for how many years, we've been using the NANDA or North American Nursing Diagnosis Association nursing diagnosis. But we're trying to basically shift to not using it anymore. You're going to hear more about it during your fundamentals and medical surgical nursing class. But these are the examples of NANDA nursing diagnosis. So one would be your knowledge deficit, pain, risk for injury, and what you're going to be seeing more now, especially in our community college, in our program, you're going to see a lot of problem lists or medical diagnosis. So now, because that's what's going on outside school, so that's what's going on during basically your current practice. So a lot of the nurses will not tell you knowledge deficit, right? A lot of nurses will start talking about the medical diagnosis or the problem list. So an example would be hypertensive crisis or even just hypertension by itself, sepsis, or pneumonia. So as you can see, it's basically your medical diagnosis. Now, this book, your textbook, actually talks about human needs statement, which is also an acceptable way of identifying your patient's problems or concerns during your shift or for your plan of care. An example would be freedom from pain, related to would be what's causing, right, that pain. So related to, for in this case, in this example, would be fractured wrist. E/B would be evidenced by. So what's your supporting evidence? What is it telling you? How come you think that the patient is in pain? So the signs of the patient being in pain or signs and symptoms would be grimacing, heart rate of 110, and the patient reporting pain level is 10 out of 10. So this is basically an overview of what's your nursing diagnosis or problem list. Again, we're going to talk about it more during your fundamentals and or medical surgical nursing class. The next step would be planning. So, as you know, planning. So, planning consists of two things, right? So, you have your goal. So, what is it that you want to achieve for your patient? So, make sure that that goal, right, is measurable. It needs to be realistic for that patient, for the current situation, because not everything will be the same for every patient, even if you have the same problem, right? So it needs to be objective, measurable, and realistic within the established time frame that you stated for your outcome criteria. So what do you mean by objective or measurable and realistic? An example, let's say your problem would be hypertension, right? So what is my goal for my patient with hypertension? Let's say your patient's blood pressure has been running systolic of 150s, right? And your goal, a realistic and measurable goal, would be to decrease the blood pressure, systolic blood pressure, to less than 140. So that's measurable, right? You have a specific number that you want to achieve, so you can measure that. While if you just say lower the blood pressure, yeah, it's a nice goal, right? But how do you know, right? You need to be specific. So how low do you want it? Do you want it 80, right? So make sure it's measurable and is it realistic? Because if I have a patient whose blood pressure is 200 and then my goal is saying by the end of my shift, my patient's blood pressure is less than 110, guess what? That's not very realistic and that's not safe. So remember, it needs to be objective, measurable, and realistic. And you have to have a specific time frame, right? So what's your outcome criteria? So outcome criteria, the first thing is, when do you want to achieve that goal? So is it a short-term goal? Is it a long-term goal? So short-term is something that's less than a week. Your long-term is something greater than a week. And also in the outcome criteria, what are you expecting to see, right? What are the things that will tell you that you've achieved that goal? And like I said earlier, for that specific patient, the blood pressure will be less than 150, less than 140. For when it comes to medication administration, this is just a general example. Let's say for drug therapy, what's your goal when you're administering your medication? In general, you want it to be safe and effective, right? So you don't want the patient to have any adverse reactions, or you don't want the medication to not work at all for the patient. So that's just a general goal for drug therapy. Again, once we have a specific patient or patient case scenario, then we would probably be able to state a more specific goal for a specific patient. So next step would be implementation. So what is implementation? So basically you've done the planning, right? So this is when you actually do what you said you were going to do. So implementation is initiating and completing your actions that you plan on doing. And this is based on whatever nursing diagnosis you've stated, whatever goals you have, and outcome criteria you set. And implementation, so implementing or your interventions can be independent, collaborative, and dependent. So independent would be something that you, as a nurse, as an individual, are able to do by yourself for the patient. Now, collaborative would be something that you would probably need to collaborate with somebody with, such as an example of that would be collaborate with the respiratory therapist to provide breathing treatments to the patient. And then another kind of implementation would be a dependent one. So dependent would be something that you will be relying on somebody else to do, or before you can actually do something as a nurse. So an example would be obtaining a doctor's order for a specific thing, right? Or a specific medication. So an example of implementation would be, so directly related to our class, pharmacology, would be administer amoxicillin as ordered every 8 hours for 7 days. Now, to be specific, I would probably say administer amoxicillin by mouth, whatever, 500 milligrams by mouth as ordered every 8 hours for 7 days. So I'm going to talk about it more later on, but take note that I also stated how much I was going to give and what route I was going to give it. And you have the frequency and the duration there. But for now, don't worry about the specific details. Just know that part of your implementation is actually administering the medication. Speaking about medication, so let's talk about the rights of medication administration. Now, throughout the years, I've heard so many versions of it. I've heard the most common one, and that's the one that we're using here for our program, would be the 6 rights of medication administration. But if you ever go somewhere else, some other school, some other hospital, you probably will hear about the 7, 8, 9, 10 rights of medication administration. But the most important thing that I want you guys to know are the 6 rights. And again, wink, wink, this is something that you have to know throughout the nursing program for this specific class, for probably your other classes, for clinicals, and throughout the nursing program, and probably throughout your nursing career. So this is something that you have to absolutely know. All right, so one would be the right drug, right dose, right time, right route, right patient, and right documentation. So some people will rearrange this a little differently to make it easier to remember. I say, well, you can actually change it around. I would probably, to make it easier to remember for you guys, I'd probably change it to starting with the right patient. So if I start with the right patient, right, you can imagine yourself. So before you give a medication, right, you want to check the 6 rights. So make sure you do the 6 rights. You enter the room, you verify that you have the right patient. That's number 1. Then you look at your medication, right? Is it the right drug? Do you have the right drug? Okay, and then following that you have the right drug, then you check, do you have the right dose? And then followed by, is it the right time to give this medication? And is it the right route? And lastly, when you're done with all of that, you will have the right documentation. And although right documentation is basically by itself, I usually like to add right patient education, because that's a very important part of your documentation and medication administration. Make sure that you educate your patient regarding whatever medication you're giving your patient. And so current practices, and like I said, different places will have additional rights for medication administration. So here you have the right reason or right indication, and then right to refuse. The reason why I don't think it's necessary to really add them to the list, because if we're going to do that, we're going to continue to add a lot of things, and probably by the end of, I don't know, 2025, we're probably going to have like 20 rights of medication administration. But the reason that I don't think it's needed is because the right reason or right indication, a lot of the times that will be part of your documentation. So that's usually documented anyway. And then the right to refuse. So whenever the patient refuses, right, you document that anyway. So I don't think it's, something that should be separate. That can be included in the right documentation. There are so many things that we're checking. So in addition to your 6 rights of medication administration, there are going to be 3 medication checks that we expect you to know. Again, something that you will have to remember throughout. 3 medication checks. So these are the minimum. So it doesn't mean you can't check it more than 4. So this is at least, right? You need to check it 3 times before you actually give that medication to your patient. So when do we do them? So you need to know when, right? First time you check it would be on first contact. right? When you first take that medication out. So when you're pulling out that medication, you want to check, you make sure that's the right medication, right dose, whatever's ordered, make sure that that's the right one, right? And in addition to that, during that first contact, you're also checking what's the expiration date. Is the medication that you're pulling expired? So that's the first check. Now, when do you do your second check? You do your second check as you're preparing the medication. So let's say you're pouring it in a cup. Make sure you have the right medication, or if you're opening the pill. So you check it again at that time while you're preparing it. And then the last time, right? Lastly, you check it again right before you give it to your patient. Again, don't just blindly give something, even if you checked it, but because you never know, you may have accidentally grabbed somebody else's medications. I don't know how, but mistakes can happen. So it's always important that right before you give it, you check it again. Now, like I said, these are the minimum number of times that you want to check them. Sometimes there's going to be situations where you may need to check them quite more often than that. And it's always better to do that just to be safe, right? But there are things that you absolutely have to check a little bit more. So special circumstances. So there are medications that you'll have to double check or cross check or have another nurse or another licensed personnel co-sign with you. An example would be your heparin drip. So before you do anything with that dose changes or even hanging a new bag, you need to get another nurse. So in addition to your 3 checks, you get another nurse to check it again with you before you even administer, you spike, or you change that rate. Another example would be your insulin. Now, depending on where you're at, now current practice, a lot of the hospitals now are not double checking insulin sub-Q. I don't know how I feel about that. I still feel like sometimes I think we still need to double check the insulin. But most importantly, when you're giving insulin IV, you better make sure that you have another licensed personnel or another nurse double check that insulin with you. Another thing that we do double check or cross check or have another person co-sign with us would be your PCA. PCA is patient controlled analgesia. So basically this is your medication, your opiate medication, so pain medication. You set it up on a pump and the patient has the ability to administer the medication to themselves through a button. Now, we set it so that it has limitations to prevent overdose and all that stuff, but still, before you change the settings, before you actually change the vial or the medication inside or the syringe, you have to get another nurse co-sign with you. So those are examples of medications that we need another person to double check the medication with. Now, there's going to be times when you may need somebody else again to help you figure things out, just like with medication, with MedMath. So if there's something that's kind of questionable to you, you're doing your MedMath, it's just not making sense, or you're having a hard time trying to figure out the right dose or right rate, then I think it's going to be a good idea to find somebody, just another set of eyes to see what's going on and maybe do the math with you to make sure that you have it right. And again, you may need somebody else to co-sign or double check with you when it comes to medications that are the medication orders with a very high dose, so the strength is really high or the lethality is very high. So those kind of medications, you don't want to make, as much as possible, you don't want to make a mistake, right? So you want to make sure you double check that with another person if possible, as much as possible. Now, I may have mentioned it already, but why do we do the above checks? Why? Why are we doing all these checks? We have the 6 rights, now we have the minimum of 3 medication checks, and then additional checks depending on what we're giving. Why are we doing all of this? Well, simple. Well, not really simple, but very important reason. We do that to prevent medication errors. So there are many ways to preventing medication errors. We're going to talk about it more later on this unit, but I just want to kind of give you an introduction about medication errors and prevention. So Most medication errors are actually, so according to data, according to some studies, that it's not actually because of just an individual mistake. A lot of the times it's because of something wrong with the system, not necessarily some nurses' negligence. So most medication errors occur because of the system not working. A break in the system, something is not working right. And it's not always the nurse's fault, right? Key to preventing errors. So the main thing for preventing errors, you want to make sure that those errors are reported. Now I know it's kind of scary because then most nurses, a lot of the nurses, are going to be scared to tell somebody they made a mistake, right? There's a lot of hesitance to that, but it's very important to report those errors so we can figure out what went wrong. How are we going to do our investigation when we don't even know that the error happened? And in addition to reporting actual errors, you want to also report potential errors, right? Because any close call, especially if it's becoming a trend, you want to know why, what's going on. So you want to make sure you prevent that error from happening. That's even better. So we can actually, if we can actually trend, we can study what's going on and prevent the error from happening. That's actually great, right? And basically ways to prevent medication errors. So they're advertising or they're advocating for just culture. So what is just culture? Basically, it's a non-punitive approach to error reporting. So that way, the nurses or anyone really, anyone involved in the medication administration process, that they're comfortable complaining or reporting things that went wrong. So if it's punitive, well, guess what? People are not going to talk. They're not going to say what went wrong. They're not going to report those errors if they know, let's say, that error is going to cause them to lose their job or their license. But for the most part now, if it's, again, there's going to be different scenarios, but for the most part, as long as you're reporting things, you shouldn't be getting in trouble for really minor things, especially if it's not really something that's your fault, if there was something wrong with the system. It's not you deliberately doing something that you were not supposed to do. And so all of this is also a result of QSIN initiative. So a lot of this QSIN initiative helps improve nursing practice and improve safety. That's for our patients and for ourselves. Again, like I told you earlier, we're going to talk about more about medication error prevention later on during this unit. We're going to now proceed to the next step, or well, still continuing to the implementation process or implementation part of the nursing process. So in addition to medication administration, so part of your implementation would be patient education. I think I mentioned that to you earlier. Remember, I also mentioned it during the 6 rights, right? Part of your documentation, right? Documentation would be your patient education. So part of your implementation is patient education. So implementation is not always just giving meds, right? Doing some interventions. Implementation, a big part of it is education. Education is such an important thing in the nursing process and in nursing in general. It helps the patient become more compliant, right? And it also helps the patient maintain their own health when we discharge them. So again, patient education is very important. Now, there's a lot of things to consider though when it comes to patient education, because yes, patient education is important, but we also want to consider things. There are things to know and consider to make sure that patient education is optimal or effective. So these are a list of things to consider when it comes to patient education. So are there any barriers to learning, right? Do they have any what's their cognitive abilities? Do they have any disability? What's their cultural background? Because a lot of these things will influence how they're going to receive that information or how they would prefer to receive that information. One big thing also is developmental status, right? Are we talking to a toddler? Or are we talking to an older adult? It's not going to be the same thing. So your approach with a younger individual may not be the same as an older individual. And same thing with education and literacy level. So if you're talking to somebody, even somebody who's highly educated, if they don't have a lot of medical knowledge, it's going to be very hard for them to understand what we're talking about if we don't talk to them using language that they can understand. So if we're going to start using all our medical terminologies, we're going to lose them right in the process. So we want to make sure that we know where they're coming from. How do they want to receive information? Now, if you're talking to another nurse per se, that would be okay to use your medical jargons, medical terminology. But if, let's say, you're talking to a cop, right? A police officer, they may not know what you're talking about. So you want to make sure that you talk to them in a manner that they can actually understand without being demeaning, of course. Now, this is the continuation of the list. And make sure, what's their emotional status. So this is all things that you want to consider. But one thing to consider is emotional status. Now, if somebody's grieving, let's say you have a fetal demise, right? Do you think it's a good time to educate your patient right after they found out that their baby's gone? Of course not. So you want to time that. Okay, and this is some more of your considerations when it comes to patient education. So again, what's their health belief, right? What do they believe in? What's their language? You can talk all you want, right? But what if they don't even speak the language at all? Then, you need to consider that. Now, limitations, right? Do they have any limitation? Are they deaf? Are they blind? You definitely have to consider that. Oops. Sorry about that. Let's see here. Again, continuation of patient education. Please read all of them. Now, I don't expect you to memorize all of them, but definitely know that we need to consider a lot of these things when we're giving patient education. So again, when you're giving patient education is very important, but you want to be aware of the patient's readiness to learn or the family member's readiness to learn. Are they ready? What's their religious belief? And are they capable of taking care of themselves? And what's their sensory status, right? Those are very important things to consider when it comes to patient education. Anyway, let's move on to the last step of the nursing process, which is evaluation. So evaluation is part of the nursing process. So this step lets us know if we achieved our goal, right? So it determines if we're heading to that direction, right? If we're getting closer to our goal, or are we going farther away from our goal? So this is monitoring the patient's, when it comes to medication administration, we're monitoring the patient's response to drug. So like the example that I talked to you guys earlier about the blood pressure medication, let's say, the patient with high blood pressure. So if I identify that the problem is high blood pressure and I wanted the blood pressure to be less than 140 before the end of my shift, and I gave a medication, so I administered an antihypertensive or blood pressure medication, I evaluate. So I go back, right? Evaluation is reassessing or checking again. So I recheck, let's say, the blood pressure. I recheck the patient, right? I examine the patient as a whole, ask the patient how they're feeling and all that. So unexpected outcome would be blood pressure will lower down. So we'll go down to, an example would be from 160, it's now down to 150. Now it may not be within my goal yet, but the response is what I want from the patient, right? We have an expected response. Now, unexpected response would be I give the medication and I go back to evaluate, right? To make sure that, if the patient has any reaction to the medication or if the medication is even effective. And the patient says, well, nurse, I'm dizzy. So that's an unexpected response. Now, that's part of your evaluation. So basically, you evaluate the patient. So what happened after you implemented what you said you were going to implement? So again, when you document that, so part of your evaluation, it needs to be clear and concise. You need to be very specific. When you're documenting something, make sure also that you're just documenting facts, not like how you feel. So let's say you say the patient reports my after the medication I got dizzy. When you document that, you basically say what it is. Patient stated whatever makes me dizzy, right? But you can't say, oh, I think the patient is dizzy because the patient may not be drinking a lot of water. That's not stating fact, that's your opinion, right? Unless you observe the patient and you know for a fact that that's what's going on. So make sure when you're documenting, it's clear and concise. Again, so evaluation is what we do to make sure that we achieve our goals. This is how we can find out if we met our goals or we did not meet our goals, right? So that tells us, okay, we may need to change the plans. Now, what is a therapeutic response? So after we do something for the patient, after we implement it, we check any signs and symptoms. We check the vital signs. We check their labs. It is also an opportunity to check for side effects or unwanted effects or adverse effects. So adverse effects are actually very similar to side effects, but they're more severe and they're secondary to the medications that we gave. Or another thing that we're evaluating for, especially for patients who've never been on a specific medication that we're giving, is allergies. Are they having an allergic reaction? One thing that's very important also to evaluate, especially after discharging a patient home, is the patient compliance. So compliance, we want to evaluate. So because if we're not evaluating that, and let's say a patient comes back to us and per se blood pressure is still high, but they already increased the blood pressure medication, but we don't even ask them, are they taking their medication? It may be because they're not taking their medication, not necessarily that the medication is not effective. And again, knowledge. So this is connected to the patient education piece, right? We evaluate the knowledge of the patient. And the best way to evaluate the knowledge is having them teach us back the information that we give them. So when you educate a patient, don't ask them, did you understand? Because they're going to say yes. Ask them, could you tell me in your own words what I just said, right? So that way you know for sure that they understood or part of whatever information that you relay to them, they absorb, hopefully, right? In our nursing program, you will hear or read about this a lot, but the roles of the nurse as it relates to basically for the specific class is medication administration. So what's our role? We're provider of care, manager of care, and members of the profession. So provider of care, basically we're the ones doing the care. So we're providing the care to our patient, administering that medication. Manager of care, basically we're planning for the day, making sure that the timing of the medication is right, coordinating with let's say the respiratory therapist to make sure that the breathing treatments are given. Now, member of the profession, that would be making sure that our own knowledge, right, that we're up to date, our license is not expired, that we're doing our continuing education, that we're really active members of this profession. So that's that for roles of the nurse. Now you're gonna see, read, and hear about it more. And actually, you can look at your student manual, and you'll be able to read a little bit more about the roles of the nurse as a provider of care, manager of care, member of the profession. Now let's move on to legal considerations and drug legislations. So first would be your Federal Food and Drug Act, which basically required drug manufacturers to list on the drug product label, and basically let the consumers know if there was any dangerous or addicting substances included in that product. So it's recognized in the U.S. Pharmacopoeia and National Formulary as printed reference standards for drugs. Another legislation that was very important is Shirley Amendment. So not only, in addition to the 1906 FFDA, now not only you're reporting anything dangerous in your product, but now they're requiring or they're prohibiting drug companies to claim that, let's say, medication A is this miracle drug that will fix whatever illness, right? When it actually doesn't do that. Now, the Federal Food, Drug, and Cosmetic Act of 1938 amendment required drug manufacturers to provide data providing safety with FDA review. So now they can't just claim something. They have to really give us the supporting evidence as actually a safe drug to take. And they also established the investigational new drug application process. So now you can't just bring a drug to the market. It needs to go through a process. Another very important legislation is the Kefauver-Harris Amendment of 1962. So basically, this required manufacturers to demonstrate both therapeutic, so that they're actually working, and also safety of new drugs. So this was brought to, basically, the legislation happened secondary to the thalidomide tragedy. So if you guys are not familiar with it, this was a medication that was used many years ago. Basically, it was marketed as a medication for pregnant women that were nauseated. So it was to treat nausea. Now, they started to notice that a lot of these women who use that medication gave birth to babies with defects or missing arms and limbs, right? So that prompted this legislation. Now, in 1970, we have the Controlled Substance Act, which is basically a legislation that established the controlled substances and promoted education regarding addiction and research and treatment on controlled substances. Now, in 1991, they established the Accelerated Drug Review Regulations, where if there's, let's say, a medication that's under review, or even if it's an investigational one, they accelerate the process because it's a drug intended to treat something that's life-threatening. So, and I haven't really checked the data, and you may correct me if I'm wrong, and I believe that's the reason why they were able to release the COVID vaccinations out to the market, because of the accelerated drug review regulation. Now, if we didn't have any pandemic going on, it would probably take us a little longer to get these vaccinations going. All right, and in 1996, HIPAA, or Health Insurance Portability and Accountability Act. Now, again, don't make this mistake. I've made it before. It's not HIPAA. So it's HIPAA, not HIPPA. So this officially required all healthcare organizations as well as schools to maintain privacy of protected health information. So basically, it's more for patient and, well, people's privacy. So it's a privacy law. So you're going to hear this a lot in this program and probably throughout your nursing career. So HIPAA. Now, in 2003, Medicare Prescription Drug Improvement and Modernization Act. So this is known as the Medicare Part D. So basically, it provides seniors and people with disability some insurance benefits so they can afford those medication, and the cost is shared by the patient to make it cheaper, and also it's shared with the patient and the federal government. Now you can read more about this legislation, so you can look at table 4.1, page 51 of your textbook. Continuation of the legal considerations. So some things that you have to know, right? What's FDA? I'm sure you heard about it. Food and Drug Administration. So this is responsible for approving drugs for clinical safety and efficacy before they're brought to the market. So all the medications, right, prescribed, all medications, treatment medications, they need to go through FDA before they get approved to be sold in the market. Drug Enforcement Agency, or DEA, this would be the agency that's responsible to monitoring and making sure that controlled substances, so especially highly addictive medications, are prescribed or used the way they're supposed to. And they're also the ones ensuring that patient education is happening, and we're making sure that we're preventing addiction. Now, there's going to be different state laws. So California will have different laws regarding medications compared to, let's say, Nevada, right? So depending on where you're planning to practice, now if you're planning to practice here, definitely look at what the state laws, because it's not always, whatever we have here is not always applicable to other states. So what's the impact of drug legislation? So what's the effect of all those laws and regulations and policies that had happened? Right. One is drug therapy. So thanks to all those changes, right, the timeline of approval changed. So again, some medications can get approved quite faster, right, in an accelerated manner, depending on which regulation we're talking about. Or some medications will probably take a little longer to be out in the market. Why? Because they have to prove that they're safe to be taken and that they're actually effective, whatever it is that they're claiming, right? Another effect is access, right? Because of that legislation, it's basically affecting how, the insurance companies are covering certain medication, what's included in a formulary or list of medications, and the cost. So there are certain things that make some medication more affordable. Now, there are things also that makes it a little bit more expensive. So legislation does affect the cost of drugs. So to bring a drug to the market, it takes a ton of money in order to bring a drug to the market. Now, cost is basically that affects everyone really, but one of the most affected population is your senior population, right? Especially when the time that they're retired, they're not able to work, and they don't have a steady income, or if they do, it's not much. So a cost is being influenced by those the legislation is influencing those costs. Now, what's another effect of the legislation? Well, some medications, right, like we talked about earlier, were withdrawn from the market. So that's actually a good thing. There are some medications that were actually not good for people. So it's good that they're out of the market. Another example would be, and I may be wrong, correct me if I'm wrong, but I don't know if any of you have heard of Vicodin. So Vicodin was a big thing even not too long ago, probably the last 5-10 years ago. But as you will notice, no one's really prescribing Vicodin anymore. Why is that? Well, I think it has to do with a lot of studies and a lot of complaints and reports, but it has to do with the toxicity of the medication. Not necessarily because of the hydrocodone part, it's more because of the acetaminophen or Tylenol aspect of it. So now what's out there is actually Norco instead of Vicodin. So Norco, the only difference is the Vicodin comes with 500 milligrams of acetaminophen, while the Norco would come in 325 of acetaminophen. So that actually made the difference. Now, general impact of legislation. So again, brand and trade names. So certain manufacturers have um, proprietary rights to medication. Now, over time, it can be released. So now that's known as generic. So when it's available as a generic, usually it's actually more affordable. And also we have the black box warning. So that basically requires manufacturers to basically put black box warning to medications that are known to cause uh, some very severe adverse reactions. So that should be within their label. And speaking of label, the drug legislation also influence how medications are used, right? So when we say label is a medication is being used the way it's intended to be used, and an off-label is something that is not often used for that specific reason. Now, what are the other effects of legislation? So what are the effects to the actual nursing profession? Well, a lot of this legislation actually force us or well encourage us to increase our knowledge, right? So a lot of this legislation required nurses to know a little bit more than just the basic things, because then we have a little bit more responsibility when it comes to medication. And in addition to that is patient education, again, as I emphasize. So now we're not just supposed to just give the medication. So in addition to just giving the medication, we also give patient education pertaining those medication that we're giving, because it's their right to know. It's the patient right to know what we're giving, why we're giving, and all those things. Some additional legal considerations and resources. So Nursing Practice Act of California. So we're in California. So this is basically will let you know what is your role as a nurse, what can you and cannot do. So definitely you can search their website. The Joint Commission, you'll hear about this a lot too. It's basically an agency that surveys hospitals to make sure that the quality and the standard of care is not compromised, and make sure they're up to level, so they meet minimum standards. Now you have your standards for Medicare and Medicaid services. You also have standards of care. So American Nurses Association, they develop professional guidelines which establishes what are the practice standards. And you also have, depending on where you're at, you have your policies and protocols. So these are going to be, usually you can search it within the hospital's website. And as an employee, I don't think the public has access to that information. But once you start working or even having your clinical rotation, those documents will let you know what are the policies and protocols with certain things. Now you have the CDC, right? Right now they're under a lot of scrutiny because of what's going on with COVID, but definitely that's another resource for you. So the Center for Disease Control and Prevention, they do have a website which you can access a bunch of information, especially now with COVID. Now you also have your Institute of Medicine, or IOM, and then you also have Institute of Safe Medication Practice, or ISMP, and Quality and Safety Education for Nurses, which I talked about a little bit about it earlier, or QSEN or QSEN. And lastly, documentation. So why did I add documentation? Well, documentation is such a big thing when it comes to the legality of nursing practice and healthcare in general. So for our specific course for pharmacology, documentation, a big thing is, what do you want to know? MAR or MAR. You're going to hear this a lot, medication administration record. So when it comes to your documentation, you have to be timely. So you want to document as timely as possible. Now, we understand that sometimes things get busy. So most nurses, if they're busy, they can go back and document what happened. But you make sure also you document the accurate time. Because the problem with that, if you don't document it in a timely manner, sometimes you may forget the details, or you may forget even when did it happen, right? So documenting, we document like our assessment findings, the drugs, the dose, the route, the time, or education that we did for a patient and the patient response. So let's say again, like my example with blood pressure, with the blood pressure case is, my assessment finding, let's say blood pressure is 160/90, so that's my assessment. Now the drug, let's say I gave a blood pressure medication, how much did they give, what route, so let's say by mouth or PO, what time did they give it. So I want to make sure that I always document in a timely manner, especially if it's a medication that needs to be given, let's say, a certain time of the day. So you want to make sure you're giving it in that time frame. And then education, did they give a patient education? And a patient response would be, let's say after 30 minutes, I go back and recheck that blood pressure. Blood pressure still a little high, maybe 150s over 85, right? So that would be your patient response. So documentation. So yes to leading zero with decimals. So we're going to talk about it more later on, especially in your calculation section. But for documentation, we document. So if it's a decimal, we add a zero before the decimal point to make sure that, we prevent any misunderstanding. Now, on the contrary, you don't add a zero, right? For, let's say, a whole number, anything. So if it's a 3, just put 3. If it's 2, just put 2. You don't add 2.0 because somebody may actually read this. For some reason, they don't see the decimal point here. They may think it's 20. Well, guess what? If somebody needs to administer something and you accidentally put 20 there, you entered an order for a doctor, they may overdose the patient. And that's 2.0 or 2 versus 20. That's a huge difference. So remember, when it comes to actual whole numbers, don't add a trailing zero. Another term that you're going to hear a lot is electronic medical record, or EMR. So this is basically the terminology that we use for the charting system. Right, so you'll hear that a lot, electronic medical record. An example of that would be the ones that we have at the hospitals. You have Epic, you also have Cerner. Now, I don't know if you're familiar with it, but for some of you with health or with experience in healthcare, you probably heard of Meditech, which is a little bit an older charting system that I think some of the hospitals are still using, not necessarily here in town, but probably some other places in another state. So this is just a picture, a picture of a nurse, right? The documentation. So most likely, if this was from a patient chart, it's either they're performing one of their 3 checks, and they're probably checking it against the chart while they're preparing it. So I'm not sure what's going on here, but basically this is a picture of a nurse checking a medication against the chart. Let's change gears a little bit. Let's talk about medication errors, preventing and responding. This is actually, I think, a very important topic that nurses should be aware of, that nursing students should be aware of. That's one of our part of our role as nurses. To err is human. So in 1999, the Institute of Medicine basically brought medical errors to public's attention. So they want to emphasize the importance of it. And they basically emphasized that there were about 7,000 deaths per year, and 3 to 6.9% of hospitalized patients experienced a medication error. So 2 follow-up reports from the Institute of Medicine found that there were no significant change in rates of preventable errors. So what are medication errors anyway? So medication errors are actually preventable. It's actually the one of the common cause of adverse healthcare outcomes. Drugs commonly involved in severe medication errors will be drugs affecting the central nervous system. Anticoagulants are a big thing, and chemotherapeutic drugs. So again, when it comes to chemotherapeutic drugs, you understand why they're also the drugs that you usually double check with another nurse. And more potential for harm are the high alert medications. So in relation to medication errors, you have your salad or sound-alike, look-alike drugs. So a lot of the errors were happening within like the medication that sounded alike or that looked alike. Or another term that they use is LASA or LASA or look-alike, sound alike. So examples of those would be your buspirone and bupropion. So when you read it, they sound like quite the same. And if you're not very careful, especially if you're in a rush, you don't check it very well, or even the doctors when they're entering those orders, they may actually end up entering a different medication, and even though that's not their intended medication. Another example would be your prednisone versus your prednisolone. So again, almost the same, right? So you can see how easy it is to get confused and actually end up giving the wrong drug or dispensing the wrong drug. And as I mentioned earlier, so medication errors, most errors are result of a breakdown in the system, not necessarily because of an individual. Now, we already talked about this, so we're going to go on to the next slide. Medication errors and adverse drug events. So what are adverse drug events? So adverse drug events are, part of it is the medication error. You also have adverse drug responses. So medication error is actually quite different from an adverse drug response. So there are different kinds of adverse drug responses. One would be an allergic reaction. So this is usually predictable, right? Well, especially if you check or if you know that the patient has certain allergies, sometimes you can predict that they may be allergic to certain medications. Now, you can also have idiosyncratic reactions. So usually that would be an unpredictable reaction. So this image right here is basically, it shows you the intersection of medication errors with adverse drug events. So if you see here, oops, sorry about that. So if you see here, you have the big rectangle here, which is basically your adverse drug events. So within that rectangle, so within the adverse drug events, you have your medication errors and your adverse drug reaction. And as you can see, here is where they overlap, right? So sometimes there are times that the medication errors actually overlap or cause adverse drug reactions. Now, fortunately, not all medication errors cause adverse drug reactions. So that's good, but it doesn't mean it's okay to have medication errors, right? Because we don't want to cause this. So what are the things that cause or contribute to errors? So errors can occur during any step of the medication process. So during procuring, prescribing, transcribing, dispensing, administering, and monitoring. So a lot of the times for us nurses, our focus is more here on the administering and monitoring part, right? Especially if we're going to be working for the different acute care, healthcare settings. This is where the nurses play a role, the administering and monitoring part. So additional issues contributing to errors, so organizational issues. So if there's something wrong within that organization themselves. So let's say a hospital that hasn't really obtained the latest, let's say, update of their automated medication dispensing machine. So that may be an issue, right? or educational system issues. So maybe we're not educating, our healthcare providers, our nurses, right? Maybe we're not giving them the right education that will help them prevent those errors. Or maybe we're educating them incorrectly. Maybe we're saying it's okay to bypass certain steps. So that can cause a medication error. And now you have your sociologic factors. And one big thing is the use of abbreviations. To be specific, the use of non-approved abbreviations. So please avoid using. If you don't know if it's a correct abbreviation, might as well just spell it out. Now you may hear this in the future, probably sooner than later. Near miss versus close call. So a near miss, what is it? Well, a near miss is an event or situation that did not produce patient injury, but only because of chance. So, and then your close call would be an event or situation or error that took place but was identified and captured prior to reaching the patient. So let me give you an example of that. So a near miss would be a nurse accidentally giving the patient, let's say, instead of 5 units of insulin, give the patient 10 units of insulin, but the patient was okay. So that's a near miss, right? So something happened, but for some reason, luckily, the patient was fine. So there's no drop in blood sugar. Now, a close call would be, an example is, this is a real life example, and I'm so proud of, she's actually a BC student. So when I was working as a nurse shift manager at one of the hospitals, one of our new grads, so a product of BC, she her patient was having an arrhythmia, and we needed the medication right away, and we didn't have it in our machine or Pyxis. So the pharmacy sent a bag. So good for her, she actually checked the label. So what had happened is they printed a label saying that, let's say, that was amiodarone, but when she checked the bag, it was actually a different medication in the bag. So luckily, that new nurse compared what was on the printed label and the actual bag. And so she didn't administer it. So we reported that, we returned it to the pharmacy, and there's really a process to that, which we'll talk about it more. You'll probably find out more about it once you start having your clinical rotation. So that's a close call. So she caught it right before something had happened. Because if she didn't do that, there would have been I don't think that would have been a near miss event, because that medication would have caused the patient to really worsen and cause the arrhythmia to be worse. So what are ways to minimizing or preventing errors? So awareness, or speak up, right? If you see something, say something. Kind of like what the example that I said. So she noticed that the label that was printed was not the same that was actually in the medication bag. So again, if you see something's wrong, say something. And then one way is now the computerized prescriber order entry. So years ago, so when I started as a new nurse, at the time where I used to work, we didn't have computer charting. So the prescribers would actually write on the chart, and guess what? Some people's handwriting were actually easy to read, but a lot of them, it was quite hard. It was like reading, trying to decipher symbols. So thank God to the CPOE, or computerized prescriber order entry. So now it's easy to read, right? Because it's just entered in a computer. And now we have the barcodes and scanning devices. So back in the day, we didn't have that. So we were just basically trusting that our eyes, that our checks were enough. But now, thanks to barcodes and scanning devices, although they have their limitations, they actually help prevent those errors. And also, again, we have the automated dispensing machines. So now we just don't pull the drawers and kind of pick which drug to take. Right now, for the most part, as long as it's working, whenever you need something, it will just open up, the right container where your right medication is at. And then again, another strategy to minimize errors is effective communication. An example would be if you're in a code, if somebody says one milligram of epinephrine, right? So an effective way of communicating, if you're the one trying to push the drug, before you push it, you verify 1 milligram of epinephrine. And after you push it, you state the same thing. 1 milligram of epinephrine given, right? So that's an effective way of communicating. Don't assume, right? Make sure that, you communicate, you openly communicate, and it's clear and it's understandable. So there are types of medication errors. So one would be a no error. So all those circumstances or events occurred that could have led to an error. It didn't happen. Now you also have the medication error that caused no harm. So that would be your near miss. And then medication error that causes harm, which is very unfortunate. And then you also have the medication error that results in death, right? That's pretty scary. But again, we want you to have the tools to hopefully prevent these errors from happening. So I don't want you guys to be scared of this and really control how you're practicing, because sometimes then you hesitate to do a lot of things. But what I can tell you is if you follow the right steps, right? If you do the right thing every time without doing shortcuts that are actually not part of the standards of care, guess what? Your chances of making a mistake is actually very, very low. And again, going back to policies and procedures, you cannot go wrong, or at least you cannot get in trouble if an adverse event happened, but you followed everything to the T. You are not at fault. So remember that. Don't create shortcuts that are not proven to be safe and or effective. So these are additional ways to preventing medication errors. So please read all that. So there's going to be a lot of layers of checks and safety checks to prevent those errors. Again, this is additional ways or steps to preventing medication errors. We talked about it earlier. That will include your 3 checks and your 6 rights. Here, still a continuation. Now, I want to talk to you about this a little bit more. So how do you prevent errors? One, you want to make sure you're assessing your patient, right? You don't give a medication without really checking on your patient first. And you don't just assume. So let's say, again, with the same example, hypertension. Patient came in for hypertension. You don't just give a blood pressure medication without checking or assessing your patient first. Did you at least check the blood pressure before giving that medication? So assessment is a big part of it, because guess what? If you didn't check that blood pressure and you gave the medication to find out, right, the blood pressure was 90 before you give it, then you have an error. Then you have an adverse, then you may have an adverse event, because what can happen is that blood pressure may go down even lower. So you don't want that to happen. So assessment is such an important thing. Now, we emphasize it a lot in this program, 2 patient identifiers. The common ones, you ask the patient their name and their birthday. Always, don't just assume. And do not administer if you did not draw up or prepare it yourself. If somebody gives you a syringe, no label, no nothing, you didn't see them prepare and say, hey, give this to patient so and so. How comfortable are you in giving that medication? What I tell you is don't do that, because at the end of the day, you don't know what's in there, right? Especially if they didn't label it, right? Who knows what's in there, right? So you don't want to ever do that. If you did not draw it up yourself, you didn't prepare it, or you didn't see it being prepared. Because sometimes during emergency situations like those, they will do that. But you want to make sure that you saw them draw that medication. You don't just get something, let's say, from a nurse in the hallway and say, hey, can you give this to my patient? Absolutely not. And another way is minimizing verbal or telephone orders. So some doctors will still try to get away with this, but actually that's being discouraged, right? They don't want a lot of the hospitals and a lot of the safety agencies, they're basically discouraging physicians and even, well, nurses, from doing verbal or telephone orders. But if you must, right, if you have to, make sure that you repeat the order to the prescriber. So again, like what I told you earlier, if somebody says epinephrine 1 milligram, you repeat that epinephrine 1 milligram to make sure that you're in the same page. Now, you can also spell the drug name aloud and speak slowly and clearly. And of course, if it's something that you didn't understand, you didn't hear well, sometimes, you don't want to sound like you don't know. But it's always better to ask and clarify than to assume that it's one thing when in fact it's not. And one way, especially as a new grad, you want to list the indication or why is the patient receiving that medication against each order. But then again, over time, certain things you're probably going to know without even listing it. So these are still additional things to do or steps to follow to prevent medication error. Please read this part. Again, please read this part, and we're going to talk about it some more during your calculation section. And for these steps, I want you to know that I want to emphasize that when you're giving medication during your when you're preparing medication, so anything pertaining to your medication administration, you want to take time to learn, your techniques. Don't just go there if it's something that you never learned before, right? You don't want to do that. You make sure that at least you have an idea on how to do it. You practice, or you have somebody who has the skill. One big thing, read the labels, right? That's what saved that patient, the patient of the new grad from BC, right? She read the labels. And again, use generic names to avoid the sound-alike trade names. So again, here additional steps to preventing medication error. So please read them. All right, so now let's do a case. Try to answer it on top of your head and see if you have the right answer. So this case, right, the nurse is administering a drug that has been ordered as follows. Give 10 milligrams on odd number days and 5 milligrams on even number days. When the date changes from May 31st to June 1st, what should the nurse do? A. Give 10 milligrams because June 1st is an odd number day. B. Hold the dose until the next odd number day. C. Change the order to read give 10 milligrams on even numbered days and 5 milligrams on odd numbered days. D. Consult the prescriber to verify that the dose should alternate each day no matter whether the day is odd or even numbered. So, what's your answer? Okay, the right answer is D. So although option C seems reasonable, the nurse does not have the prescriptive authority to change the order. Therefore, the prescriber should be consulted to verify the order, which can be written in clearer terms. The other options would result in a change in the alternating dose schedule. Again, so like with this scenario, if it's so confusing, please clarify and don't assume. As I emphasized earlier before, when it comes to preventing more medication errors, it's very important to report medication errors. So make sure, if an error is identified, you report to the prescriber, so the doctor or PA or NP who prescribed it. And also you basically escalate depending on your policy or protocol. You basically report it to the nursing management, and depending on your policy and procedure, you may have to document on an event reporting system. Now, what would you document? So it needs to be factual documentation. No need for excuses, no need for explanations. Basically say it as it happened. What happened, right? So medication, let's say, what medication was administered, what was the actual dose, what's your assessment or evaluation findings. So after that, what did you observe with the patient? Were there any signs and symptoms? And then make sure also that you document that you've notified. So make sure you've done it, right? And then once you've done it, make sure you document that you notified the prescriber, and also you document if there were any orders by the provider. So in addition to the internal reporting, we also, a lot of the facilities are required to do external reporting of errors. So they're required, or sometimes they're voluntary reporting to the United States Pharmacopoeia Medication Errors Reporting Program, MedWatch, sponsored by the FDA, and then Institute for Safe Medication Practices, and also the Joint Commission. So now let's change gears. Let's talk about ethics. So what does ethics mean to you? Basically, ethics would be talking about doing what's right. So sometimes something that's ethical doesn't mean that it's legal, or vice versa. Something that's legal is not always ethical. So in general, ethics would be, what's morally right. The American Nurses Association has a code of ethics. Please read it. It's actually in your BC nursing student manual. So please find it there. Be familiarized with it. So that's an expectation. That's what the ANA expect us nurses to behave ourselves, right? Next, we're going to be talking about ethical terms related to nursing. So these are going to be terminology that we expect you to know. All right, so one would be autonomy. So what's autonomy? It's self-determination and the ability to act on one's own. Next would be beneficence, or doing or actively promoting good. Confidentiality, so duty to respect privileged information about a patient. So this is where, when it comes to legislation, this is where HIPAA takes place, right? Confidentiality. Justice, so being fair or equal in one's actions. Non-maleficence, the duty to do no harm to a patient, or at least not intentionally harming a patient. Veracity, the duty to tell the truth. So these are the terminology, ethical terms that we expect you to know. So please remember this, memorize this. Next, we're going to talk about the legal and ethical principles. So elements of liability for nursing malpractice. So what are the things, right? What are the elements? What are the things necessary to call something a malpractice? So number one, duty, right? A person should have, let's say a nurse, for example, has a duty to a patient. So let's say the nurse is responsible, or that's part of her job description. So let's say nurse Anna is assigned to patient A, right? So she has a duty for that patient. Now, breach of duty, So let's say Nurse Anna is not doing her responsibilities or her job description. So, for example, the breach of duty would be, let's say Anna was assigned for patient in room, patient A did not give the medication that was supposed to be given, right? There was a breach of duty, so she did not perform her responsibilities. So the causation, so the breach of duty leading to a negative outcome. So what would be the causation in this case? Well, let's say Anna was responsible for patient A, did not give the medication. Now, patient A fell down because the patient had a stroke, right? So because the medication that was not given, right, it led to a stroke. Now the damage, so the patient now has a stroke. Now the patient is disabled. So there was a negative outcome as a result of the breach of duty. So that is what you call a malpractice. So that in that scenario, there was a malpractice happening. So that nurse was actually liable for nursing malpractice. Why? Because one, she had a job, right? She did not do her job right, which, right, led to a negative event, and that negative event caused some damage. So it had a lasting or negative outcome for that patient. So that is what comprises nursing malpractice. So ethical consideration, again, ANA Code of Ethics for Nurses, and then we have the International Council of Nurses Code of Ethics for Nurses, and then placebos. One thing that I want to talk about is ethical dilemma. So that's going to be something that you may be encountering as a nursing student and even before nursing, right? And you may have this happen to you quite a bit when you're working as a nurse. So examples would be informed consent, right? What I can tell you is that caused a lot of dilemma for me, especially when I used to get orders from doctors saying, obtain an informed consent from the patient. And whenever I talk to, let's say, a patient, they said, well, they would report to me that they haven't even talked to the doctor yet. So informed consent, to me, informed consent, and in general, informed consent is when the patient already was informed and supposedly I'm just a witness to that. And for me to make a patient sign without them actually talking to the patient, it just didn't feel good to me. So some doctors and even the OR would get mad at me, but I would just tell the patient, don't sign this until you talk to your doctor. And sometimes it causes a little bit of delays, but you know what? If it's not an emergent surgery, it's not an urgent thing, and they have time, that should be something that should happen. And I do recommend that you do the same thing. Don't be comfortable and don't be okay when the doctor or the provider would ask you to obtain an informed consent when there was really no informed consent because they haven't even talked to the patient yet. So make sure that that happens. Also, a lot of the things that can happen in a clinical setting is disclosing medical conditions. So let's say you have an adult person and a family member asks you, please don't tell, let's say my mom who is 60 years old, who's with it, right, alert and oriented, there's, cognitively they're there, and the daughter or son asks you, please don't tell them, let's say that they're dying of cancer. Yes, it's, you understand where they're coming from, but at the end of the day, right? That's the patient right, right? And they're adults, and if they want to know what's going on, which is their right, you should be able to tell them what's going on. Again, that's usually for initial diagnosis, unless it's just for patient education purposes. But for initial diagnosis, that would be, let's say, the provider's job, right? Whoever diagnosed that patient. And no one really has the right to hide that information from the patient, especially if they're legal adults who understand what's going on and they don't have anyone representing them, right? Another ethical dilemma is incompetence among peers, right? If you see somebody who's not doing a good job, or you don't think that the quality of care that they're giving to the patient is right, sometimes it's easier for people to just not say anything. But again, you see something, say something. I mean, I know, especially if they're your best work buddies, right? You have to say something, because at the end of the day, why are we there? It's not really for anything else but to make sure that we give safe and quality care to the patients. And I think it's just, it's a disservice to the patients when you know that somebody is not doing their job right, and that can jeopardize their safety. And one more thing is the code status versus the advanced directive. So a lot of the times that can cause a lot of ethical dilemmas, because then you can have family members whom want everything done when you know as a provider and you know as a nurse that the patient is suffering. So where do you go from there? What I can tell you is it's always good to know yourself. So reflect on your own principles, what you believe in, right? Follow the policy and protocol. So not because you feel a certain way that you're just going to deviate from the standard of care, from your policy and protocol. Follow that, right? And if anything is in question, um, you can escalate it to your higher ups and basically consult what to do in certain situation. And lastly, you have a lot of the hospitals will have an ethics committee. So you can consult with the ethics committee if it's something that you can't really figure out or you need a little bit more assistance with. Now let's talk about drug classification. So you have prescriptions, which includes your controlled substances, and you have your OTC or over-the-counter drugs, and you also have your herbal supplements. So what are prescriptions? So for prescriptions, these are medications wherein the orders are required. So it allows control of drug, the dose, the number dispensed. So it basically enables healthcare provider or the prescriber to make sure they're in control or they're guiding appropriate treatment, and also making sure that patient education is happening and they're able to monitor for or limit the side effects. So example of prescription medication would be your blood pressure medication like lisinopril, metoprolol, and also your antiplatelet or anticoagulant, which is your clopidogrel. Now, you don't have to know this, specific details about these medications, but these are example of medications. These are medications that a patient cannot obtain unless they're prescribed, right? Unless there's a doctor's order. Within that prescription, we have our controlled drugs. So again, as mentioned earlier, right, the Controlled Substance Act of 1970, basically they became more strict when it comes to controlling the controlled medication, and they established schedules for controlled substances depending on their effect or addictive properties. So these controlled medications, they have a potential for abuse and addiction, although they do have medical benefits. And sometimes dependence can happen, so patients can become dependent. And when you take them off of it, withdrawals from the medication can happen. So schedules of drugs, so they are based on abuse addiction potential. So it's from low to high, and also their medical benefit. So what are the prescribing requirements? So most common is the Schedule C2 or Schedule 2 drugs. So with this one, they used to require written prescriptions. Now it's really not needed anymore, but the provider should be the one ordering it, and they should have a second way of basically they should have a key or some sort of a signature that can be sent electronically that only the provider can do. And that helps prevent, people from just sending, or making fake prescriptions. So you have category 1, so only with approved protocol. So we don't really see this much. What we see a lot is category 2. So again, these are requiring before written prescription only. So depending on what state too, because I know in Nevada, they actually require the written prescription, but here in California, they're allowing electronic prescriptions. So just, depending on which state you're at. But for our purposes here in California, electronic prescription is okay, but the provider prescribing has to go and they have an additional step, basically additional step to be able to prescribe it. So you can't just freely prescribe it just like that. There are steps to verify that you are you, and then somebody else is not prescribing it for you, even in using the electronic records. And this medication, oftentimes they don't have refills and they have a warning label. So example of this medication would be your codeine, hydrocodone, morphine, and hydromorphone. So you also have category 3. So category 3 is you can have it as written or oral prescription. It expires in 6 months and no more than 5 refills in a 6-month period. And it also has to have a warning label. So an example would be your Tylenol number 3, so acetaminophen with codeine. And with this category, it's commonly medications. They're commonly the medication mix combined with codeine. And you have your category 4. So category 2 and category 4 are quite common. So they have very similar requirements for prescriptions. So it can be written or oral prescription. It expires in 6 months and then no more than 5 refills in a 6-month period, and must have a warning label. So example of this would be your phenobarbital, the benzodiazepines, which is your lorazepam, alprazolam, diazepam, and etc. And you also have your tramadol in this category. And last but not the least, your category 5, they can be written or over the counter. It varies by state. So examples would be some cough medications and some antidiarrheal. So depending on where you're at, there's going to be different medications that are available for people to purchase without an actual prescription. But usually they limit the amount of how many they're going to dispense. Again, for controlled substances, medication labels, so they must have warning labels. Like it can cause dizziness, can cause addiction, withdrawals, etc. So again, like an example would be may cause drowsiness. Moving on, we have the over-the-counter medication. So in the outpatient setting, you don't need an order for it. However, if you are in an inpatient setting, so let's say somebody's in a hospital, they can't just, let's say, start taking whatever they're taking at home. There needs to be an order to continue taking that in the hospital. So just know the difference. Usually, over-the-counter patient can take without orders, but if they are in a facility in an inpatient setting, then they have to have an order. And that's to make sure that we're not overdosing, double dosing, and whatnot. So generally considered lower risk of abuse, so in wider range of safety, and they're at the lower cost. So potential problems for this. So sometimes patients' knowledge, they're available in the market. So whatever it is that the patient knows about the medication, sometimes they may not necessarily know what it is for. An example of this is my dad. He uses aspirin for everything. If your stomach hurts, aspirin. And I know somebody it was very sad. So I had a friend, she was staying with us for a little bit, and she had a stomach ache, and I think she had some ulcers. And my dad, he basically said, "We'll take some aspirin." Guess what? It made it worse. So that's a potential problem, right? So if you don't know much about the medication and it's so available to you, that can cause some side effects or that can cause some adverse effects. Again, self-medication. And so with that self-medication, they may be taking medication A, which is prescribed by a provider, and they're also taking this over the counter. Sometimes there may be some drug interactions. And, especially if they're not reporting it, we don't know. So that's a downside to over-the-counter medication. And another thing is there's still a risk for overuse and abuse. Most common one is, again, kind of like what I told you about that example. They take aspirin for everything, or ibuprofen for everything, or Tylenol. And a lot of times they don't really follow the directions, like how often they take it and how much to take it within what time frame, right? So there's still a downside to it. Examples of over-the-counter medications would be your Tylenol, ibuprofen, aspirin, diphenhydramine, or Benadryl. So those are your over-the-counters. Next would be your herbal supplements. So what are the advantages of herbal supplements? Well, they're readily available and they come from nature. And a lot of the people who actually are into this, the healthy stuff, a lot of them, they believe that herbal supplements are so much better. It's often considered natural and preventative, and it's thought to be lower cost, which that can be debatable because a lot of the herbal supplements now are getting a little bit pricey. But then again, if you compare it to certain prescribed medications, then they may be able to save some money by taking the herbal supplements. Um, Let's see. Next would be, what are the disadvantages of your herbal supplements? Well, formulations are not regulated. So sometimes, the companies can just manufacture certain herbal supplements and they're not regulated by the FDA. And so that can, their active component, their inactive component may vary. And there's no standard for reporting them, right? There's no clinical trials involved, you know, so there's no data supporting their safety either. And it can have variable strength. It's not basically, you don't know if whenever you take one capsule, if you're getting the same amount of that active medication. And again, just like the over-the-counter, so self-medication and drug interactions. So there are medications that you may be taking, or the patient may be taking, as prescribed by their provider, and unknowingly they start taking herbal supplements that can actually interact with the current medication that they're taking. So examples of herbal supplements that are quite common is the St. John's wort. It's thought to help with depression, the black cohosh that helps with menopausal symptoms, the ginkgo. A lot of people say it helps with the alertness and memory. Redis rice. So that's actually, I can tell you though, I take that as a supplement. It does help with cholesterol. So again, it may work for some people, it may not, but when it comes to myself, it did work for me. So redis rice, cholesterol, and saw palmetto is for prostate health. So these are going to be herbal supplements that you may be seeing, or sometimes you may need to actively, ask your patients because they may not necessarily report it to you right away when you ask them what medications are you on. So make sure you're specific and you ask them specifically, are you on any herbal supplements, such as, name some examples, right? So that's your herbal supplements. So, what are nursing responsibilities in medication administration? Well, like I told you earlier, knowledge. So we're responsible for the knowledge we need to basically know. And also, in addition, part of that is the medication reconciliation. So medication reconciliation is basically, trying to compare what medications the patient came in with, whether to continue it or not. And then whenever they move from one area to another, is it changing? Um, Part of our responsibility is definitely safe administration and patient education. In addition to that, we also were responsible for documenting. So again, MAR, right? So that's where we document. And then automated dispensing. So Pyxis our Omnicell. This is the machine where we get the medication and it documents when the medication was pulled out. And also another responsibility, so this is related to your controlled substances, is count and waste protocol for controlled substances. So when it comes to controlled substances, a lot of them you're required to, depending on your policy and protocol, we count them before taking a medication out. If there's any discrepancy, we count them again. And depending what your role is in the organization, you may be responsible in, counting them at the end of the shift, depending on the policy. So counting and wasting protocol. Oh, in addition to the counting, so wasting protocol. So you can't just waste a controlled substance down, let's say, down the drain You have to have a witness, so you have to show somebody, right? Not just co-sign, because I see that a lot. Some people just say, hey, can you sign this for me? But in fact, they haven't seen that person waste the medication. So um, per our law, policies, and protocol, when it comes to wasting controlled substances, we have to witness it. So actually visually see how much they're getting rid of, and there's a proper place of disposing it, and there's a proper way of documenting depending on where you work as a nurse or where you're at as a student during clinicals. So this picture is basically a nurse. It looks like she's looking at something in the so this looks like the Pyxis. So this is one of the automated medication dispensing machine. So yeah, so that's part of our responsibility. And lastly, cultural influences. So as we know, culture plays a big part, and we're in a country where there's different cultures and we're mixed, and there's a lot of people from all walks of life, from all backgrounds. So in doing all of that, right, within our responsibility, we need to take in consideration the culture, right? What are the people's beliefs about illnesses? Because that can influence how they're, how receptive are they with your patient education, or how compliant are they going to be, or are they even going to refuse or accept, or accept that medication that was prescribed for them. Do they believe in alternative treatments? Are they doing anything, or do they believe that something is, let's say, a punishment from God, therefore they're not going to be willing to take medications? And again, culture can affect and influence diet. So what food are they eating, right? And so we also have religious considerations. So please, when it comes to cultural influences, read page 49 of your textbook. There's a summary of common practices among some cultural groups. Now, this is just a general thing, but I don't expect you guys to stereotype either or generalize that everyone from this background does this and everyone from this background does this. Because even if they belong from a certain culture, you need to you can't just assume. You need to ask and verify, because again, in addition to belonging to a culture, right? A patient at the end of the day is also an individual. So they may be a little bit different from other people. So make sure you consider that. Anyhow, I know this was a lot, but thank you so much for your patience and for listening.